Okay, thank you, Samrad, for that introduction. Um, am I visible? Is my slide up? I just want to make sure everything's okay before I
Yes,
launch
you're
it.
visible, slides are up, and we can hear you.
Okay, fine. I appreciate the chance to be with all of you today, and I thank the WACP for giving me this chance. I think my remarks, as you'll see, will complement many of the issues that Lawrence has just been speaking about, and also provide a historical dimension to some of the questions about cultural formulation and case formulation more generally. I'm speaking with you from Switzerland, and as I'm sure you all know, we have many nice trails here. And one of the things that I've learned is it's a good idea to know where you're going when you start out. So I'm going to begin by highlighting the route and waypoints along the path that I plan to take with you over the next 20 minutes. I'll begin by making a point that may seem obvious to most of you, and in fact, which Lawrence has covered to some degree, and that is simply the fact that social and cultural issues are frequently considered collectively and interactively. But we also have to keep in mind, and this is a point that I think is going to be central in many of the remarks that I make today, that events and awareness over the past few years have highlighted the distinctive mental health impact of many social issues, such as discrimination, deprivation, and social justice. Structural racism, the Black Lives Matter movement, caste discrimination, and coloniality, they all suggest the need for psychiatry to re-examine how we work. And in large measure, I think that the remarks that have been made earlier are part of that effort to do that rethinking. Within the field of cultural psychiatry, they also suggest the need to reconsider the structure and methods of cultural case formulation. The Outline for Cultural Formulation, the OCF, was published in 1994, and it now needs some updating. I'll explain why and how. Considering approaches to case formulation identifiable in historical schools of psychiatry and mindful of current priorities, I'll explain the rationale and features of a proposed revision of the OCF as a sociocultural case formulation. This touches on some of the questions and current priorities that were mentioned earlier. And finally, I'll conclude with some reflections on challenges likely to confront that process. Well, first, about what the case formulation refers to, what any case formulation refers to. In his book, Approaches to the Mind in 1973, one of my teachers, Leston Havens, wrote, "Psychiatry has evolved a powerful group of methods, we can say technologies, that govern the relationship of therapists, investigators, and their patients and subjects in each of the major schools." Well, we can think of a case formulation as one of those technologies. It's a way of organizing clinical information that helps a clinician interpret a patient's problems and needs so that the clinician can apply professional skills to be helpful. What kind of information about a patient is relevant in a case formulation? Well, to answer that question, you have to consider which school and professional orientation you're getting that answer from. Certainly it's symptoms, but what about dreams, sexual fantasies, personal and group identity, housing and financial status, access to opportunities? Organizing clinical data in a case formulation is not just for a clinician to plan treatment. It's also used in other ways. It shapes professional clinical communications about a patient in case conferences and for case records and for publications and research. Although common usage of the term case formulation is itself relatively recent, we can readily imagine the shape and examples of case formulations from case reports and the literature in various subfields of psychiatry. Let's consider some examples before returning to the question of reconceptualizing case formulation in cultural psychiatry. Emil Kraepelin's objective descriptive psychiatry is the basis of the current dominant role of nosology and the clinical task of eliciting symptoms to make a diagnosis according to the DSM or ICD. That approach, declaring what the problem really is and naming it based on signs and symptoms, is a positivist process. As Havens pointed out, Kraepelin's overriding interest was in disease and disease processes in the pathological tradition of Virchow. Rudolf Virchow, of course, was not just a 19th century German pathologist whose contributions to classification in the fields of pathology and medicine are monumental. He's also a foundational figure in the origin stories of the field of social medicine. And I'm going to say more about that later. For psychoanalysis and depth psychologies, the clinical tasks of assessment and treatment were less well differentiated than they are for objective descriptive psychiatry. Symptoms are regarded not so much as indicators of disorders as they are manifestations of intrapsychic processes, that is, unconscious thoughts, feelings, memories, and drives. Analysis of patient-clinician transference also reveals crucial psychodynamics. Psychodynamic case formulations explain patients' problems based on psychic content uncovered in the course of analysis or psychotherapy. Psychic content that validates premises of psychoanalytic theory are highly valued features of case formulation, those case formulations in psychoanalysis, especially content related to the impact of sexual experience, fantasies, and the role of Oedipal conflicts. In the field of existential phenomenological psychiatry, Karl Jaspers was a major contributor. He earned his medical doctorate in 1908 in Heidelberg, where the influence of Emil Kraepelin was still very strong. Jaspers became dissatisfied with prevailing approaches to mental illness. He questioned both Kraepelin's emphasis on diagnostic criteria and methods of clinical psychiatry to elicit them. Clinicians should focus instead, he argued, on learning the subjective mode of patients' experience. His approach relied on the power of shared empathy. The clinician is to feel what the patient feels, a feeling experienced during which objective understanding is postponed. R.D. Laing characterized Jaspers' work as the first serious attempt in psychiatry to reconstruct the other person's lived experience. That priority, of course, also resonates with later developments in medical anthropology. Harry Stack Sullivan revised clinical priorities in yet another way. Instead of the diagnostic, intrapsychic, or subjective, he focused on the interpersonal. Symptoms in psychosis were not static. He regarded them instead to be a product arising from social interactions. According to that view, cultural formulations explain symptoms and mental health problems as dynamic products of interpersonal interactions. Participant observation, Sullivan's preferred clinical method, aimed to clarify a patient's feelings in response to the perceived attitudes of the clinician or of others. The clinician was an active participant in exploring patients' feelings. Note also that interpersonal interactions were not just between two persons, but also within families, hospitals, and perhaps society and culture as a whole. With advances in psychopharmacology in the 1950s and 1960s, biological psychiatry became ever more influential in the 1970s. The trajectory of George Engel's interest moved in the opposite direction. After earning his medical degree in 1938, he trusted only biological explanations of disease processes and was skeptical of psychological alternatives. But later, with training in psychosomatics at Hopkins, Harvard, and the University of Cincinnati, his views changed, and Engel himself became a major contributor to the field of psychosomatic medicine. As a professor of medicine, and a professor of psychiatry, working in consultation liaison psychiatry at the University of Rochester. He commanded authority when he cautioned about the dominance of biomedicine. He warned that it had displaced critical social, psychological, and behavioral dimensions of illness. His publications, especially his 1977 article in Science, proposed the influential biopsychosocial model. He recommended it as a blueprint for research, a framework for teaching, and a design for action in the real world of healthcare. For Engel, and in the other schools of psychiatry, the meaning of social was for the most part or exclusively interpersonal. Matters of politics and policy, poverty, working and living conditions, access to healthcare, class discrimination, and social justice, these were all largely ignored. In Europe, the middle of the 19th century was a tumultuous period of revolutions. With his experience at the barricades in Berlin and with insights from investigating an epidemic among a stigmatized minority in a deprived rural area of Prussia, Rudolf Virchow became acutely aware of the health impact of politics, poverty, and both health and social policy. He was not just a doctor, but also a politician and an effective communicator. In 1848, collaborating with his psychiatrist friend, Rudolf Leubischer, Virchow established a popular journal to advance a movement for medical reform. That work and his continuing advocacy for progressive health and social policy embody values that endure in our current understanding of social medicine. It inspired community health movements in pre-apartheid South Africa and in other parts of the world throughout the 20th century. As we turn our attention now back to the question of rethinking case formulation in psychiatry, 2 points are critical to keep in mind. First, there's the question of what clinical information do we want for case formulation from a clinical assessment? Second, there's a more subtle question about how the information that patients tell us is used in a case formulation. Do we prioritize patients' views and self-appraisal as we would in existential phenomenological case data or for illness explanatory models? Or alternatively, do we reinterpret what patients tell us with reference to professional theory, as we do in assessing diagnostic criteria or analyzing transference that elucidates intrapsychic processes? Furthermore, some clinically relevant information might be better obtained from other sources, apart from what patients are able or willing to say in clinical assessment interviews. We also need to consider a third key point. That is, how does a clinician go about the task of getting clinical data for a case formulation? Well, the CFI in DSM-5 was a response to that question, and Lawrence already spoke about that to some length. One might expect it to provide relevant cultural interview data for a cultural formulation based on the OCF. But acquiring information and organizing it in a case formulation are two distinct tasks. Although the CFI was inspired by the OCF, each had a different topical structure. Though complementary, the frameworks of the CFI for obtaining clinical information and the OCF for organizing and working with clinical data are different. Experience in the field trial for the CFI in India indicated not only its value, but also several problems. On the plus side, validation studies showed that the process of administering the CFI was regarded as positive and helpful by both clinicians and patients. But it was difficult to map information from the CFI onto the OCF framework. Furthermore, societal structural issues, which were important in the content of patients' interviews, were not addressed well enough in either the CFI or the OCF. Since the publication of the DSM-3 in 1987, the DSM and ICD systems have authorized criteria-based diagnosis as the preferred approach to clinical case formulation. To acknowledge the relevance of culture missing from the DSM-3, a national task force on culture and psychiatric diagnosis was established, and it met in April 1991. The outline for cultural formulation, OCF, was a product of those deliberations, and it was included in the DSM-4 as Appendix I in 1994. Since then, the outline for cultural formulation has been used as a framework for published case studies, for training in cultural psychiatry and in cultural competency. The Cultural Formulation Interview, CFI, was developed, field tested, and included in DSM-5, published in 2013. Outside the DSM and ICD frameworks, spurred largely by the abomination of persisting systemic racism in the United States, principles of social medicine motivated efforts to promote benchmark skills of structural competency in medical education and mental health care. The OCF served as a guide in the DSM-4 for addressing cultural issues. The 4 topical domains of the OCF are shown in the slide, and Lawrence has already reviewed them for you. Clinical information for an OCF case formulation comprised an unacknowledged mix of what patients said in clinical interviews and in either interpretation of what they said or information from other sources. This slide shows the relationship between each of the questions of the CFI and the 4 topical domains of the OCF. The colors for the OCF domains, yellow, green, blue, and orange, are mapped onto each question of the CFI. Note that some multicolored questions, numbers 6, 7, 9, and 13, address the interests of more than one OCF domain. But more striking, note that most of the questions are green. That indicates the predominant emphasis of the CFI on illness explanatory models. Inattention to structural issues is not just the limitation of the CFI and OCF. It's now recognized as a pervasive limitation of psychiatry that can no longer be neglected. In the various schools and orientations of psychiatry, social factors typically referred to interpersonal social relations rather than social or societal structural issues. For example, consider the role of loss and bereavement among diagnostic criteria in objective descriptive psychiatry, object relations in psychoanalysis, the focus on interpersonal, group, and family therapies, and the meaning of psychological and social in Engel's description of these in the biopsychosocial model. The priorities of structural competency training, though, are different. In assessing patients' problems, social is regarded as more societal, as it focuses on political, economic, and systemic determinants. Justification of a structural formulation was also based on criticism of the limited scope of the cultural formulation in cultural competency training and inattention to structural issues more broadly in cultural psychiatry. Jonathan Metzl introduced the term structural competency in 2009 in his book called The Protest Psychosis: How Schizophrenia Became a Black Disease. Helena Hansen writes, structural competency was a reinvention of social medicine. The emphasis on medically informed advocacy for health and societal reform follows directly from the fundamental priorities of Virchow's medical reform in 1848 and subsequent formulations of social medicine. Based on our experience in the CFI field trial in Pune, India, the research team, led by Dr. Vasudev Paralekar, proposed that the structure of the OCF should be revised. The content revision was particularly notable for inclusion of domains that better differentiate social relations and societal structural issues. The revision also dropped the domain addressing the patient-clinician relationship. Patients had been reluctant to discuss that in the CFI assessment interviews. Working in the framework of the proposed SCF, sociocultural formulation, it was also clear that we could elicit patients' views, their self-appraisal on their own identity, social relationships, and structural issues. But a fuller appreciation of the significance of these topics often required information obtained from other sources. This slide presents the proposed framework for a reconceptualized sociocultural case formulation, SCF, to replace the OCF. Domain 1 on cultural identity and Domain 2 on cultural concepts of illness remain fundamentally as they were in the OCF. Note, however, that various aspects of illness explanatory models, which are pervasive throughout all domains of the CFI, are consolidated in Domain 2 of the SCF. Domain 3 addresses social interpersonal relationships of all kinds. Relevant issues concerning the patient-clinician relationship are now included among them. Domain 4 focuses on social issues explicitly involving societal structural determinants. These include political, economic, and health system matters, eco-social issues, and so forth. Inclusion of this domain is intended as a corrective response to inattention of the OCF to the values of social medicine. With that in mind, the rationale for reconceptualizing Domain 4 in the SCF may be understood as analogous and much like the inclusion of the OCF itself in the DSM-4. Adding the OCF was similar as a corrective response to inattention of the DSM-3 to culture. Okay, I hope the argument for reconceptualizing case formulation in this particular way is clear. I'll conclude now with some reflections on challenges to the dominance of the diagnostic formulation and challenges to the proposed revision of OCF as SCF. In the real world of mental health systems, substantial practical constraints limit personnel, time for patient-clinician contact, and access to services. The culture of medicine and the commercial pharmaceutical interests all favor a simpler diagnostic formulation. Furthermore, within the field of cultural psychiatry itself, the OCF has become entrenched. It was difficult enough to get it into the DSM-4, and now, more than 25 years later, it's become resistant to change, despite ever more glaring limitations. The structural competency framework is currently outside the DSM system, though it's clearly on its way in. The way it relates to cultural psychiatry, that is the approach to structural competency and that framework, however, recalls past rivalries that limited pluralistic integration among earlier major schools of psychiatry. For proponents of the structural competency approach, cultural psychiatry seems insufficiently attentive to matters of politics, economy, discrimination, and related issues that are central but too often ignored. For many in the field of cultural psychiatry, it seems that shouldering the responsibility for bringing about major societal structural change in the course of their routine clinical practice is daunting. Even though there may be agreement on the need, it seems unclear how to fulfill that responsibility. And from the vantage point of cultural psychiatry, it also seems that structural competency critiques dismiss the relevance and power of empathic attention to cultural issues and the patient's voice. These are some of the issues confronting acceptance and use of the SCF, and more generally, the process of reconceptualizing case formulation. Thanks very much for your attention, and I'm looking forward now to your questions and comments in discussion.